let's approve the minutes from September. Anyone want to discuss or make a motion to pass the minutes from us?
Motion.
Okay, 1 second. Meetings are passed. Let's go to standing reports from the program agency director.
So you can tell by the conference brochures that conference material and registrations are out, and things are moving along. We have vendors already booking, and we have some registrations already. So things are progressing good with that. State Council meeting in a couple weeks, right after Thanksgiving. Was it December 3rd and 4th in Troy, New York? We'll see what's, I haven't seen the agenda yet, so can't report much on that. Aside from that, it's been just working with Scott with the Higher Education Committee and doing office work at the moment.
Okay, great. Anything from FLCC?
We have classes coming up in January. We have three originals, one scheduled for the Newark, Wayne Finger Lakes Blue Seas campus, one in Ontario County here in Gorham, and then one in Canada. And then we have a CFR in the North Seneca ambulance base.
Okay. All right, so we'll go to the medical director reports. I don't have anything new to report over the past 2 months, but I have to go over the citations. Let's see, there's 3 today. So I have Wayne Allen from Gloversville, New York, suspended pending a hearing on 11/14 for alleged violations of Part 800.16 I have a Tyler Fending from Lockport, New York, suspended for 1 year, effective 9/10/24. Stay pending 3 years of successful probation and a civil penalty of $2,000 with $1,000 stay pending successful probation for violations of Part 800.15A1, 800.15A2, 800.15A3, 800.16A1, and 800.16A13. Davin Eshelman from Lima, New York, suspended for 1 year, effective 9/12/24. Stay pending successful completion of 3 years probation without further violations. A civil penalty of $8,000, $6,000 suspended pending successful probation. And a medical director report is required on 12/24, 25, and 26 for violations of Part 800.16, 813. Those are the value list. I don't have anything else to report. Anything from Dr. Glick?
So for education, we had 2 education meetings, 2 education committee meetings. There's a copy of the minutes at the front for anyone who's interested. One of the first things that we chose to tackle were getting some skills in rotation. So quarterly skills. The goal would be to have the education committee pick the skills with input for whoever wants to help out. Those skills, we would have sessions where we have trainer, where we're going to have trainers from each, or evaluators from each agency come. We go over the skills with them, making sure that they're doing them correctly, pointing out the specifics of what we feel need to be really brought to the providers for, I don't want to say improvement, but things that that we want to make sure are reinforced in the teaching. It's a pass thing. It's a pass. It's not like an evaluation of numbering or rating of individuals. The idea is that we have people that we train and we feel are competent that can then bring out the skills to providers and making sure that they're keeping up with their skills. Our goal is eventually to pick things that aren't done frequently, skills that we want to make sure that we're kind of digging out from maybe from past training or initial training as EMTs and paramedics to keep our skills fresh. For the first quarterly skills, we picked things that we felt are kind of appropriate to season as well. So BLS skills and ALS skills will have kind of a matching to them in that the ALS skills will be building upon whatever the BLS skills are that we're rolling out to the providers. So for those of you that have the minutes, you can see, so it'll be respiratory assessment, BLS level and the ALS level, CPAP for the BLS level and the ALS level, BLS pharmacology, and then for ALS providers, ALS pharmacology, but also complete airway obstruction, because there was an unfortunate case recently. And I feel like it's good that we pick topics also that are kind of relevant to what's been happening in our region. So again, the goal is more to kind of keep everyone on a I don't want to say a schedule, but to keep everyone reminded of what skills and kind of sharpening those skills. And then we're going to use a tracking system that's out of actually CNY region, where providers can log in, they can attest, we can even in the future expand on it even with some questions or evaluation for the instructors as well. The next quarter after that, we were talking about cervical spine clearance, because we've noticed that there are a lot of cases where people are getting cleared for C-spines inappropriately. That's some feedback that the hospitals have gotten from the trauma centers. And the next meeting will be on December 10th. Whoever would like to join us, it's open to everybody.
If there's anybody else that wants to join this group, just let me know so I can add you to your email to the group so you're not missing out on discussion.
Okay, great. Dr. Cyron?
Good morning, everyone. I'm going to forego my report because there's a second document out there, Pilot Quality Assurance Implementation Plan. So I've been tasked with trying to develop a comprehensive quality assurance plan for the region. So this is the start of it. I've been working with several national quality organizations to try and develop something that's both achievable and relevant and helpful. It's detailed there. I'm not going to go through every section. The next plan is to get a working group together, very similar to the way we did RSI originally, where we got a working group together first. They worked on the final document, set up the system, and then ultimately that working group became the initial committee for the RSI program. We're doing the same thing with quality. We also get a little bit of help from our colleagues in Milrens, one of which is on one of the national quality measures groups for EMS. So get a lot of helpful information, and I will most likely, once we finalize it for the region, give it to them to kind of look over and make any appropriate changes. I think, and maybe Brian, I know he doesn't like to get pulled into things, might want to feed into this. We also got to figure out how we're going to engage the agencies, and I think that really the only way of engaging is a little bit of kind of carrot and stick. I think it should be voluntary for the agencies to participate and come in on, but once they commit to it, they should commit to it. There really seems to be two pathways that are very clearly defining in New York State. Quality continuous improvement pathway and an enforcement pathway. I would, if you don't want to participate in the quality improvement pathway, then the only other pathway that's open is the enforcement. So I think that agencies that participate, they kind of go down that quality route. If they don't want to participate for whatever reason, whether they don't like the people in the committee, they don't like the system, they don't like being told how to run their agency, whatever their bias is, then they will still be subjected to quality audits from the region. But rather than working with the agency to fix that problem because they're participating in quality programs, it'll just be referred to the state for enforcement action. And I think that that's going to be the easiest way. I think the Med directors should all support the quality pathway and encourage their agencies to do so. But the carrot is avoid enforcement by going down quality. The stick is, but if you want to go down enforcement, good luck to you. And like would that be a good summary of what's happening in the state?
Yes.
And
I mean,
enforce. That's what it's
the only problem that I see with, and I will tell you, the state likes the stick and carrot. We on things especially that we don't have enforcement ability over. We do it all the time. However, my only issue is that you having, I'm going to use this, partial compliance from agencies, and then you're not sending certain agencies to the state, even though they're not really complying with the QA process, but they're signed up for the QA process, and et cetera, like that. That's my only, where you're not treating every agency the same. That would be my only concern. But as long as you're treating everyone equally, whether they chose A or B, then I think that's okay.
Yeah, good. That's really good feedback. And my eventual goal actually is that if someone refers something direct to enforcement and it bypasses the Remac and quality completely, I would like enforcement to come back to the region and say, hey, we've got this complaint, can you look at it from a quality, rather than just have this enforcement unit just doing its own thing in a vacuum. Like, we should know, and I think that ultimately the goal is continuous quality improvement, not necessarily fines.
I would agree with that. My only issue with that is probably about, I don't want to say a month ago, maybe 2 months ago, they finally updated our website with the complaint process, okay? And so if someone, anyone, anonymous, non-anonymous, agency, whoever, wants to complain about pretty much anything, okay, it can go fill out the portal information and hit submit, and it goes to Albany. It doesn't come to me, it doesn't go anywhere, it goes to Albany. And then it trickles down. And once it starts to trickle down, it's difficult for us to be like, oh, this is nothing, this is whatever, it's just a agency or whatever thing, because there's documentation standards that we need to follow. So I can go to the region and be like, hey, I need you to put this through a QA, but unfortunately, it's still at that point would probably have a case number associated and stuff like that.
But that would, I think that's
still
still
bad.
good, valid information for us.
Right.
To know
Oh,
that there's
yeah.
something coming through and we can go through the processes.
As long as we don't get surprised with it when he's reading the numbers up here, and we're like, wait, what? When did that happen?
So, and James, that's the thing I'm trying to avoid
Right.
is the first thing we find out a quality problem is when someone's being fined,
Right.
which is typically a year later
Or more.
2 years later.
I think, I think going the process though, like, let's say somebody makes a complaint about ABC provider, right? And then we, on our end, somehow we get that information and there's a similar complaint that's conveyed to us. And let's say we're doing it in parallel, like the state is aware and they hasn't trickled down far enough for, let's say, Brian to tell us if we're doing a QA process, ideally, when the two kind of meet up, where the state says, okay, now we got to investigate this, and Brian's able to say, well, yeah, actually, the region already did a QA process on it. They even have a remediation plan. It's been in effect. Or they did a remediation plan and they completed it, if it's a year later, either way, it's good.
I want to open
It's
the
just,
door. I want to open the door to
Yeah.
the state having an option other than finding or suspending a measure or an agency.
I think also, because we know by practice, right? For a large majority of cases, if the state is aware that where media and providers participating in, the region's happy, I would say the provider's happy, the provider feels like they were treated well, and it did justice to the patient and the public, then the state doesn't really take it for usual, right? So, for the agencies also, that but like let's say one agency participates actively and rigorously active in QA, and another agency is not rigorously, practicing in the QA process. For the matter of kind of treating everyone equal, if you find an issue in the ones that are rigorously participating and an issue in the ones that are not rigorously participating, either way, I think that the QA process, the QA should actually make a recommendation as to what they feel like the remediation should be. And then whether they follow it or don't, that's going to be on them. So, let's say it's an agency that doesn't participate rigorously and you guys say, well, hey, listen, we found there's room for improvement in this and we think that you need a remediation. And then they give it to the agency and the agency says, nah, we don't agree, right? Then, your hands are kind of tied. Then you refer it on.
Yeah. So the two components to quality is obviously retrospective and prospective as well. So we will be developing audits that go across it system-wide that may or may not identify issues that need to be fixed or addressed in some way. So there are prospective and retrospective components to it. And then the idea is that if we find issues, then we'll hand it over to education, and then we're not going to be developing education plans.
Yes.
If we find a need for remediation, we're going to give it to education, say, give us an education plan so that we're enforcing essentially the quality committee is identifying quality problems and passing on to education that there needs to be some form of addressing or, some plan together. So it's all in there. I encourage people to look through it. I will be asking John to canvass people to participate in the working group. It will be on Zoom. It will be during the week. It will be during the day. It's all in there, so just take a look at it.
Anytime rolling out any, QA, QI process, especially one of this nature, I think that the incident reporting and the data collection is going to be, and how that gets accomplished, I think is going to be hugely impactful to how successful it is. Because if we're not catching the misses, then you're not, then QA process is what it is. If we're looking at great cases all the time, and great, but obviously we know things are going to happen, so it's making sure we capture those.
And the other component to it is when you develop like C-spine clearance, that information it should go back to quality. We're doing a C-spine clearance update, and then we should be developing a QA process to follow the C-spine clearance process for 6 months and 12 months. So it's kind of going to be this back and forward relationship between quality and education. So that's fundamentally where we're going with this. As I say, we'll get the information out, encourage participation from all regions, all agencies, and I will report back. Hopefully we'll have this fleshed out a little bit more by the end of the year and probably implementation in the first quarter of next year.
Okay, great. Any updates from the hospitals?
I don't know if any other questions specifically.
Yeah, thus far, we haven't seen the COVID and flu numbers pick up. I know that they haven't quite hit our region, so knock on wood, we haven't been quite hit with boarding yet this year. Anticipated it'll surely happen at some point in the near future. Other than that, just a thank you to several of the EMS companies in the area with We've had some intermittent CT scanner downtimes in Clifton and Newark, so really appreciate all the assistance in getting those folks back and forth. Finger Lakes, Phelps, Williamson, Ontario. I'm sure we had some other help in there as well. But we've had and getting some behavioral health transfers on both sites as well. So that said, I know those are never easy asks, so appreciate the facilitation when there's been able to be helped. So just thank yous in that regard.
James, just to follow up on your flu. So I meet every other week with the state epidemiologists. They sniff toilet water and detect COVID and do all these gross things. COVID is running flat. There was an outbreak in Buffalo and an outbreak in New York City, but it has been running flat. Flu has been flat as well, but starting to pick up.
It's picking up big downstate.
Yeah.
Western and Finger Lakes haven't gotten hit yet. It's starting to get the capital region a little bit.
Yeah. So they are anticipating declaring flu season and all the masking, and if you don't have your flu shots at or around Thanksgiving. So it's coming up. And that's important for the agencies, because the agencies are still, the medics are still subjected to those restrictions that if they're not flu vaccinated, they have to be in full PPE for patients. And then the final kind of thing on the horizon is H5N1, which is bird flu, is a kind of the street name. They've started to see a transition, I guess, to birds, and then it goes to cows, and then it goes to pigs, and after pigs, it goes to people, and they're starting to see it jump into people now. So that's the kind of the one that if we're going to get an explosion, it's going to be that. The COVID currently is covered by the COVID vaccine. It's still Omicron currently. There hasn't been a major change in it. So I think the next, infective thing that we're going to see, or milestone, is declaring flu season at the end of November. So I've been encouraging all my medics to get flu shots, to update their COVID shot at the same time. Interestingly, there's not only resistance to that. This year, the threat of going back into masks for the winter has been a motivator, and people have been getting their shots.
All right, any updates from the ground or agencies? No, okay. Doesn't look like we have any old business to go over. As far as new business, it sounds like we need to talk about the antibiotic training module. This is referring to the Moxie for open
It
fracture.
is, yeah. So it's, the state passed Moxie for antibiotic therapy and the protocols. It's in there currently. It's one of those, if equipped and trained by your local Remacs. I think, it's certainly not a bad idea. It's not going to be immediate, it's just going to onboard the medication a little bit sooner. But we need to develop some sort of training module to, make sure the medics are all up to date.
So I'll give a little bit more background. It's also IV Keflex as well. It's like Ancef IV and moxifloxacin PO are the two alternatives that were put into the protocols. It came after all the orthopedic organization, NEMSP, ASEP, and NREMT all came out together with a joint statement that said in open fractures of major limbs, people should be receiving antibiotics. There's a survival benefit to get them on scene. The oral moxifloxacin, I'm not sure, is a great, it's a little expensive for EMS and not maybe the best giving people PO anything if they've got a major open fracture. The IV Ancef, cefazolin, is far more standard of care. The national standard is, it splits it into can you give allergies, unknown allergies, or no allergy. If there's no allergies, you give IV. If there's a possible penicillin allergy, you give IV, and if they can't consent, you give IV. So they're pretty much giving it for almost everything unless you have a known cephalosporin allergy. It's minimal training. because it's 4 lines. I'm not sure how much familiarization. They all have the ability to deal with anaphylaxis. Myself and Chris Galton from Mercy Flight actually rolled out training for Wayne County in preparation of introducing it. It's already on flight already with training, and their training is exactly the same. The guidelines are freely available online. It's done by every major organization, and I didn't know if it was a Remac or if it was Med Director training.
No,
Is it agency specific or region
it's
specific?
supposed to be, if equipped, their verbiage is equipped and trained, so it's a Remac.
Yeah, but we approved
We approved the
Yeah.
protocols already. Yep.
so we did at Wayne County move forward with training with the plan of eventually getting it on our radar.
Just there's additional agencies that want to bring it on board, and there's no specific training module yet. So I think anytime we have an addition,
It was literally 1 page. So.
Yeah. It doesn't have to be a lot. It just has to be something.
Yeah.
It could go out as a single information sheet.
Yeah,
To be
that
honest
sounds
with
good.
you,
Yeah.
I can give you this. I can give the slides from our agency that we use to do it, but it's really like 2 PowerPoint slides and half a paragraph of information. I'm happy to share it.
Yeah, no, that's great. No, we don't have to reinvent the wheel.
And then we're just simply doing attestation on
Yeah.
one of the sites and good to go.
Sounds good.
Perfect.
All right, the next thing we want to talk about is RSI applications. Which agencies are currently applying for RSI?
Mike, you want to take that?
Do you have the applications or?
Yeah, let me run and grab them.
So 2 agencies have put in, one is Yates County ALS, formerly the Med 55 program had the RSI, that no longer is in existence as a unit, and the other one is Ontario Ambulance. And I have one provider in Melrose that put in RSI credential in Melrose, Brian Bartlett, he works at Hunter Richmond. I have that application. So it's Ontario, Yates County. I haven't heard from Penny Ann. I don't believe you have ketamine yet. Is that correct?
No, we're still waiting for state approval.
Mark Lee also used to be a flight medic for a long time. So
Yes.
Can I ask a question?
Yeah,
You just updated your controlled substance policy and submitted the changes to that, and you're waiting to hear back?
oh, they must have just submitted for a new,
Yes, the answer to that is yes? Okay, I'll look into it. I will tell you. Very, very rarely. You actually ever hear back on the policy, change things, so, yeah. You can just want to move forward. Just assume that it's assumed, but I will check into it further.
So,
are we voting on?
yeah, Julie's correct.
Okay.
I need a motion and a second. I motion to approve.
I'll second.
Do you meet the criteria? Do you meet the criteria?
All right, so I believe that's all on the agenda. The next Med Director on call, I think, is going to be you, Dr. Glick.
I can do this one.
Okay, so for the next 2 months, it's going to be Dr. Glick. If you have any issues or any concerns, and then you'll run the next meeting. So I'm going to make a motion. Anyone want to make a motion at the meeting?
Sorry, Tom.
No. Email us for that traditional stuff too.
Okay, thank you.
Email us for that traditional stuff too.
I had a motion, that was it.
Sorry, my voice is still not quite there.
Do you want to be on the list?
The last meeting I was working on.
Yeah, I can, make sure I
I was.
Yes.